Invite our panelists to join me here. Angela Chen and Midnight, Nini Tun, Felipe, Joaquim. And that's all who will join us here. And I think that during these talks we have learned a lot about like the national systems level of how you really plan ahead to integrate stigma discrimination into something that is actionable and measurable. That is very impressive. And we may want now here to ask our panelists to also share how they see this at another different levels as well, like the individual level or the intersectional level, the other settings aspect as well. So we have 20 minutes or so here, and that will eat into your coffee break time a bit. I'm so sorry about that, but please bear with me here. Without further ado, I may need to introduce each of you first very quickly, sorry. So we have Angela Chen here, who is currently a 5th grade medical student. I think it is the first time that we have medical student on the panel like this at APACC. So welcome, Angela. She's from the National Taiwan University, and she was elected as the president of National Taiwan University Medical Student Association for the year 2022 to 2023. And she conducted several workshops on HIV, stigma and discrimination, along with the HIV week to advocate for correct mindsets of AIDS for the students. And then we have Midnight, which may not need introduction, but I still need to do it for formality. Midnight Phun Kaset Vattana is the Executive Director of APACC, which is based in Bangkok, working in multi-sectoral partnerships with governments, donors, the United Nations development partners, and most importantly, the community and civil society organizations working on advancing SOGI rights and elevating HIV in Asia Pacific region. And then we have Nini Tun. Haven't seen you for so long in person, so welcome, Nini. Nini started work as HIV-TB National Coordinator with MSF in Myanmar in 2003. She trained more than 1,000 local doctors and just joined the MAM, Medical Action Myanmar, as a medical director in 2009. And since 2019, Nini is working on HIV innovative and research advisor for Medical Action Myanmar and Myanmar Oxford Clinical Research Unit. So welcome, Nini. And last but not least, Felipe, Joaquin Reyes, I hope I pronounced your name correctly. If not, please accept my apology. We can call you Quino. Right, Crino is a Filipino lawyer, LGBTQIA+ and HIV advocate and yoga teacher based in Manila. Crino is a co-founder and director of the Philippine LGBT Bar Association, the first association of LGBTQIA+ lawyers in the Philippines, as well as legal counsel and director for membership of the Philippine LGBT Chamber of Commerce and organization of LGBTQIA+ professionals and businesses that promotes diversity, equity, and inclusion in industry and public policy. So we have quite a range of panelists here. So feel free to think of questions that you may also want to help me ask the panelists here. But first, I would like to start by asking Midnight. I'm not going in order, so please be prepared here. So to start with Midnight, we have heard a lot about like HIV related to stigma discrimination related to HIV, related to key populations, and I think we may need to be like educated more or discuss more around intersectional stigma and discrimination. I just would like to ask you, from your perspective as a community representative, why do you think we need to discuss intersectional stigma and discrimination.
Thank you so much, Dr. Nitya, and also the other co-chairs, Mark and Danvik, for organizing this wonderful Asian Stigma Discrimination Forum. Thank you, Dr. Teresa and Dr. Anita. I think they already mentioned about the intersectionality work on stigma discrimination, and I think, for over 4 decades of HIV/AIDS, particularly from the community organizations, you already know that there are systemic issues that HIV alone doesn't address, and that's why it's so important that we have community-based organizations as part of the service delivery to ensure that criminalized behaviors, people living with HIV, and working with people is not just about the disease only. So that's why I think the issues around the intersectional stigma discrimination on a personal level, for everyone here, I think you can imagine, going to a hospital, you're not just a one box, right? I'm not just a gay man going into a health service. I might want to talk about other issues as well, and not just about HIV. And within the service delivery, and it's not just about getting the service only, it's actually being treated with dignity and with respect. So that's where our work still continues. And as the Malaysia and Thailand already mentioned, there are a lot that's happening within the healthcare settings, and that's great to see that there's a lot of involvement from the community organizations to be part of the monitoring of those services and how to ensure that the quality of services will also increase. We need to also ensure that service delivery models also integrate other care and services as well. For transgender women, might not be about HIV, right? It's about hormone treatment. Is that being integrated within healthcare settings? Criminalized behavior such as people who use drugs, is that being discussed? Are you able to talk about that with health providers within the government-based facilities? So it's about trust building. That will take a long time, right? But we already have that built within the communities. That's why the targets for the UN at the moment, 30, 60, 80, and also the 10-10-10 target is actually looking at policies and laws that needs to be diminished and be broken to ensure that people are not criminalized for their behavior and can feel free and can be part of the citizen and can demand the same access to services. It's also looking at how communities can also take an active part in terms of service delivery, treatment, prevention, outreach, the whole gamut of the cascade. And I think that's where then within the discussions within the communities, we can really ensure that the intersectional stigma can then be talked about within the community-led monitoring in partnership with not just the government's organization, because as Dr. Anita mentioned, sustainability is also important as well. How do we ensure other sectors, particularly the private sector, can also take an active part in terms of the service delivery model that is ensuring the rights of everybody and ensuring that everyone will have a humanized treatment and be treated with dignity in healthcare facilities. Thank you.
That was wonderful, Midnight. You mentioned about the humanized healthcare, which I think like many of us here start working in HIV. We are so humanized healthcare providers, but we may not be that humanized anymore. So that really reminded us of how we should think about ourselves first as an individual level of effort to try to address stigma discrimination. The 10-10-10 and the 30-60-80 targets are also very important, and I believe that should also be integrated into the national level, like the systems level of addressing stigma and discrimination as well. Thank you. And my next panelist that I would like to invite to give a comment is Nini. It's the same question, Nini. What is it about intersectional stigma and discrimination from a healthcare provider perspective? You have seen so many clients during the very challenging times in Myanmar, and how do you have get those experiences to share with us?
Thank you. I think before I start to talk, I have to ask how much time do I get?
I can
talk
have
the
2
whole
to 3
day.
minutes for each, and then we can go to
Okay.
for the next round.
Thank you. Very nice to see you all. Thanks for inviting me and to give me a chance to talk about this intersectional stigma and discrimination. Well, at the beginning, the intersectional is like something you might feel that something the vocabulary you never know before, but actually it is in our daily life. So it is that stigma is very complex. So especially in our region where HIV is concentrated among key population. So that is already stigmatized. So in Myanmar, for example, we have main 3 key population, which are the female sex worker, men who have sex with men, transgender women, and ingesting drug user. So these people are already stigmatized by being the group that they belong. So the stigma, just to categorize three groups. One is related with health, which is HIV, of course, it's a big thing. And the second one is related where you are followed the group of marginalized group, for example, like gay men with transgender women. It's already stigmatized. And the third one is people interpret as sort of morality or bad behavior. They define that group, which is sex works or maybe injected drug use, substance use. So these people are already, you see, it's not really simple one HIV-related stigma. It is related with the complex thing. So as a healthcare provider perspective, when I was working in a hospital in early 2002-3, and I remember that HIV positive, you will see the patient at the end of the ward. They are kind of like infectious ward. So I was a junior doctor. I don't know why do they put there, but actually they have a low immunity. They should be away from the infectious disease, the other airborne transmissible disease. But actually it was like that, and there is no counseling there. I never learned how to do counseling at that time. Then I joined with MSF. Then I remember I began the doctor to take care of female sex worker in China border, in the northern part of the country. And my family didn't agree with me to join that job because they are worried that the attitude of female sex worker will be transmitted to me. So I said, well, I mean, I am the one who is going to do behavior change. So, you know, I'm not going to let them change me. So you see, that I came from a middle-class family. So this is what happened in the hospital. So I think I'm talking a lot. So that's why intersectional stigma is complex. And in my country, it's a huge issue. And that is a big barrier for prevention and also treatment. Therefore, many people who are high risk, which is key population, they are afraid to do HIV testing. They are even afraid to take PrEP. So that is a bigger thing we are fighting right now because PrEP is only allowed to be used for MSM and transgender in the country. That is double stigmatizing for the group. So we have to do, but I think the QI program that I learned this morning is quite impressive. And my colleague has presented very successful program. I wish that my national program has a chance to join the next time. Yeah, thank you.
Thank you. The idea that certain attributes of an individual can be infectious. That's true. That's really true. You know, like all of us, some of us as a doctor working with LGBT, our parents are really afraid that we will become LGBT one day, which may be true, right? I don't know. And yeah, and so thank you very much, Nini. And my next question is to Felipe, which is around the same thing, like because you are from the legal supporter perspective. So how have you experienced intersectional stigma?
I think I'm better suited to talk about how employers address stigma. I mean, we talk about stigma in a healthcare setting, right? But for people living with HIV, how often are they in a hospital? Maybe once a month, once a quarter, whereas they are at work at least 5 days a week, right? And so in our experience in the Philippine LGBT Chamber of Commerce, of course, we talk to our members about these things and they refer these matters to us. Most employers in the Philippines in particular are in a bind because the law requires Philippine employers to have a specific HIV and AIDS policy in the workplace, right? Which includes certain benefits, including more flexible leave arrangements, and also support. But how can employers offer these things to their employees without outing the employees when they avail of these benefits, right? And that's where intersectionality comes in. By offering similar benefits to other key populations, whether it be people who may be dealing with mental health issues or tuberculosis, or maybe people with disabilities, nobody is outed, and a lot more people are able to avail of these benefits. And so we reduce the stigma by offering a lot of these benefits and arrangements to a wider base of people. And although the issue in terms of employers is that they don't really, well, so far from our experience, they have not really conducted the same qualitative and quantitative analysis of these policies. Like there are, from what I know, no quality improvement measures in place. But all that we do know of is based on what the employees say, right? And more often than not, the employees air out their grievances or their requests not directly to the employer, but mostly in the context of employee groups, support groups, which are on the rise in the Philippines, but in particular for certain groups. So I am not aware of any PLHIV support group in any company or in any workplace in the Philippines, but there are a number of LGBTQIA+ groups in certain employers, particularly in certain industries, such as in business process outsourcing. And that is the venue where people living with HIV are able to air out what they need to say, and then it is then transmitted to the employer. And similarly, it's the same thing that happens for other support groups, whether it be a women's support group, a people with disability support group. So it follows the same model.
Maybe just one quick follow-up question to that, because I think many organizations, workplace, are now getting into that DE&I, the diversity, equity, and inclusion principle of how you will make your business grow, right? Do you think that having HIV as like one diversity among these DE&I will help, or will that further stigma?
That's a very good question, actually. I think it depends on the context. Recently, the Philippine LGBT Chamber of Commerce hosted and organized the first Inclusive Philippines Business Summit, wherein we brought together a number of organizations, women's group, people with disabilities, indigenous persons. We did consider whether we want to bring in people living with HIV as a separate category within that summit. Of course, the summit was open to everyone, right? But then we didn't realize that, considering the nature of Philippine culture, it might not be the best idea. Currently, even there's still a big pushback, in particular against LGBTQIA+ people in the Philippines, and so we decided that it would make it more general, to apply to a bigger segment of, to more key populations and a bigger segment of the population. But we did tackle some issues related to that. So I think if the setting were more specialized, for example, or the participants or the community would be more open to people living with HIV being at the forefront, then it would be okay to bring them to the forefront. But if you realize that there is some discomfort or pushback, then maybe just include them in the broader population of participants.
Great answer. And Bruce would like to add to that?
Yeah, I'm really glad you brought up the issue, both of the workplace and the DEI. Back home, actually, the diversity, equity, and inclusion movement has been a powerful tool for engaging stigma reduction activities and sustainability of those activities. So it's something to keep in mind, even if they're just starting out in some countries. I think the workplace standards and the ILO standards are another place to look at ways to include information about equity. And lastly, just to say we have a lot of work to do because, and we all have experience as advocates, but with the movement toward universal health care with a focus on primary care, it's going to be even more important to bring the issue of stigma and discrimination in key populations to the forefront of discussions as integration moves forward. So thank you.
Wonderful. Thank you so much. And now to Angela. You are so unique here because you are still student. Some of you may be the students, maybe PhD students, master students, that's also counted. So my question to you is that because, you know, in our generation of implementers in the field, we feel quite exhausted, and sometimes we lost hope in addressing stigma discrimination with this generation of healthcare providers, et cetera, et cetera. So what is your view on this? Can we and should we or must we start earlier, and what would be the practical ways of doing so?
So I want to first thank the organizers for having me here, and on behalf of the medical students in Taiwan, it's very happy to share my perspective to you all. And I would like to start with a story that I experienced last year, which is my first year of being into the clinical environment. So as a medical student, we are supposed to handle a primary care patient in every ward. And when I was in the gastrointestinal ward, my senior wants to assign a patient to me. And when he say, oh, you are responsible to this patient. And when the nurse near Alphas heard it, and she say, oh, you sure? He is H. And then I was like, what's H? And then after figuring out, I totally figured that, oh, he is the HIV patient. But I was so confused that in my past 4th year in medical school, I do have learned some medical knowledge about HIV. And I didn't know that I was like, HIV was nothing so terrifying, why they are saying that. And that was my first experience to spot the stigma and discrimination even in the clinical environment. And it creates the story followings. So I was elected as the president of Student Association and the medical for medical in our medical school. And I think as a medical student, there do exist some ways to deal with the stigma and discrimination. And the one I want to say is that the most direct and effective way to put our focus on is through medical education. Since from the observation of clinical environments and the participation of student affairs for a lot of years, I think it's the most effective and efficient way to shed our light on the younger generation. It's kind of hard to change the old generation mind, and it's flexible mind for us to change the way our thoughts, our attitude, and our behavior in our younger generation. So I think there were 2 ways to start with our medical education, both officially and unofficially. Officially means within the course. For the medical education, we think the hospital can give us a chance to approach HIV patients as a medical student. We don't have to do some invasive procedure, so we don't actually in that possibility to be infected. But if we have a chance to actually talk with those patients, I think it's open our curiosity, it's open our mind, or give up, or spot out our curiosity to make us to learn more about what HIV is. And then we will know what they think by approaching those patients. So as a medical student, we don't have to do a lot of things. We just need to do the history taking and the physical examination to the patients. I think through the process, we can talk to the patients and then know their story and then know why they don't have the insights or don't have the desire to tell others to identify themselves. And the second thing we can do officially is to encourage medical students to do volunteer service in NGO. Since medical school in Asia are mostly undergraduate system. So basically in medical school, we don't have a lot of chance to interact with other students from different departments. We all stay in a closed system that we're all influenced by our senior, who are already stereotyped. Yeah. And so we have to encourage medical students to reach out, to contact to different social organizations. Like for example, in Taiwan, there is Person with HIV Rights Advocacy Association of Taiwan and Taiwan Ludus Association. Those two NGOs is very famous for eliminating HIV stigma and discrimination. And for those two are the official method we can do to deal with the HIV discrimination regarding to the medical education. And for unofficial ways, which means through extracurricular activities held by student association, I think it can be more different and diverse ways. Yeah, and for one, like we medical school consist of a lot of committee. If you are familiar with International Medical Organization or Association, you may heard of IFMSA, International Federal Students Association of Medical Students. And there is a committee standing called SCORA. If you are interested in, you can type in as CORA in any browsers you have. And then with connecting to International Medical Students Association, we and Taiwan Student Association do is to highly connect to them and know what is happening in the world. And then when I was in my sophomore year in medical school, when I was just a part member of Student Association, we, SCORA, a standing committee in our student association, like a little department of the whole student association. We took part in Taiwan LGBT Pride Parade in 2019, which led to the first legalization in Asia to same-sexual marriage. So it was really a good experience to open the medical students' sites and then their horizons to see what's happening outside the medical school. In conclusion, I think the information of medical students should not be just restricted to the textbook or only medical system. We should put more emphasis on make they reach out, to make them have their own experience through participation connected to the real social reality and community. And I'm here to happy to hear everyone's feedback regarding to medical students or medical student perspective in Taiwan. Thank you.
Wonderful. Thank you so much, Angela. I mean, I feel refreshed hearing that, you know, because when we talk about stigma discrimination education in medical schools or nursing schools, we always think about just like curriculum. But what Angela suggested to us, it's more than that. When it's good, it's nice to have that curriculum, and we don't have that in any, I don't think we have that in Asian medical schools for now. But to think beyond that, to think about the informal way of engaging students and not like just close their mind why they are still having all these flexible minds, that's very important. Thank you. And I know we are running out of time, so before I end here, I just would like to ask our two speakers here, Dr. Anita and Dr. Tuisap, if you would like to make any comment and any final words for all of us here.
Thank you. I think I just would like to echo what Angela said about training medical schools or nursing schools. I totally agree with her because, you know, when we can always include a curriculum, you know, related to HIV awareness, stigma, and everything in the curriculum, medical school or nursing school, but they will learn it for the sake of passing the exam, right? Right? Okay? You learn that for the sake of passing the exam. But believe me, once you graduated, you forgot what you learned. So therefore, when we want to tackle SND, it has to be involving the community, trying to understand and work with them. That will make you understand who they are. And it will automatically or over time will erase your fear about working with them. And again, it will also erase the misconception or misunderstanding that behavior or high-risk behavior is infectious or contagious. Okay, that's all. Thank you.
Thank you. Dr. Tuisap, please.
My point would emphasize on the thing that when we're talking about the stigma and intersectional, everything intersection and not try to bring just one issue in to do things success, but we have to go for the common thing that every party in the community, both sides get along, and then we work together to be universal, not just, so that would reduce the inequity and make the diversity more beautiful, not to separate or discriminate. If we get together on the common goal and find the positive approach that we are working together, intersectional, everyone would be willing and get together. And when we're working together, be careful that sometimes we may have some stigma attitude or do something that discriminate, but not the problem. But at least we aware, and then we try to do things, and that we can act together to end the discrimination in our community and get people universal access and free form of discrimination in our community setting. Thank you.
Thank you so much. That's a very beautiful ending for all of us to aim towards eliminating stigma and discrimination in our lifetime. That should be our mutual goal, and to really see that diversity is really beautiful. Thank you very much. So please enjoy the coffee break, and thank you all the panelists here, the speakers here.